we're tackling the policy issues, and we're tackling the everyday questions on diabetes that Roland, myself, you watch, and everybody will be asking as well. But Derek Akol-Sam is in Kumasi, and we rove on issues, so we decided to tackle this one on diabetes. But first, we hit the streets in Accra to find out what people know about diabetes, and then we will talk about the sugar projects.
It's a disease that is caused by the lack of insulin or the body's unresponsiveness to insulin being produced, resulting in excess sugar staying in the blood. We can do a lot with our diet. We can do a lot with regular medical checkups. And then those who are already diabetic, unfortunately, some are born with it. We have different types. Type 1, type 2, and then those who get it when they are pregnant, called it gestational diabetes. So it depends on which type you have. If you have type 1, it's difficult controlling it with diet. Basically, you have to be on insulin because it's caused by the lack of insulin. If you have type 2, maybe you had it as a result of your lifestyle, then lifestyle changes will help a lot, particularly your diet and being on regular medication. If it's gestational, you are pregnant and as a result your blood sugar level goes up. Basically, after delivery, we expect that things will normalize.
Diabetes is a sickness that is from like when you like taking sugar, a lot of sugar, it gives you like it will form a sore in you, and when it's too much it comes out. That's the little I know about it, but I don't know much. How to prevent it is just you not take much. You have to limit the way you take your sugar.
Diabetes a disease that can kill so easily, and it's dangerous too. So eating of sugar, and then there's a lot of fat. Just control your diet, visit the hospital on time, and doing checkups.
You have to limit the sugar intake in case when it comes out, it can even cut your leg or something like that.
How does it come out to cut your leg?
It comes out like a sore. When it comes out, there's no treatment for it, so it can even cut your leg or your hand or something like that. By preventing it, you have to limit your sugar intake in it.
What I know about diabetes is about too much eating of sugar, and then a lot of drinks. When you drink too much, alcohol and other varieties, so that one man have to control.
Normally, it comes about when you take in sugar, a lot of sugar, but the sugar is not only limited to the normal sugar we take. It comes about in taking foods that contain sugar, rice. There are some kinds of food that you even take that can cause that. But one thing you have to know is that you have to watch your diet. Eating a lot of on-whole meals can cause diabetes. If you don't exercise also a lot, it's more prevalent in men. One of the symptoms is you urinate a lot, you start to sweat a lot, you want to drink a lot of water. So when something like that happens, it's better you go and see your doctor and find out exactly what is happening. And I know it can also even lead to stroke.
When your blood sugar goes up, we don't really know what causes it. But we know that diet and then lifestyle issues are involved, as well as hereditary issues. So if you have a family history of it, you are at a higher risk of, being diagnosed later in life than somebody who hasn't got a family history of it. I would advise the general public, go check your blood sugar levels, check your body weight, check your diet, check your lifestyle. If you live a very sedentary kind of lifestyle, you are not exercising your body enough and all of that, it makes you prone. And then also, if you have a family history of it, then you should be more conscious. So you go to see your GP and then have your blood sugar levels regularly, monitored. And that would be of a very good use, yeah.
Well, so now let's do the discussions, because now we have the specialists in the studio. We'll have those who look at the day-to-day issues as far as diabetes is concerned, the kind of education and literacy actions that they tend to give their patients. And also we talk on the policy actions, both local and international. We have in the studio Professor Alex Dodu. He is an expert in pharmacovigilance, and he is with the Collaboration Center for the WHO here in Accra. I would say thanks for joining me. I've known him for a very long time, and so we have that collaboration already. And Dr. Ebenezer Odro Mensah is a family physician, a medical superintendent with the La General Hospital, also in Accra. Thanks for joining me.
Welcome.
Okay, Doc, 2 docs, 1 prof, all docs at the same time. But let's talk on the subject, and let's talk about you, because you tend to see patients often as much as you can. But we're hearing the statistics that since 1980 it's quadrupled. We're in excess of over 420 million worldwide. In the US, for example, 1.5 died from a certain type, etc. And it's all complications. For all the world things that we talk about, how serious an issue is it in Ghana?
Well, I can't give you the exact numbers, but judging from outpatient attendance, it is a serious issue, because it's one of the most common chronic condition aside hypertension that we manage in our outpatient settings for most primary care settings. And the complications, when you go to the secondary and tertiary facilities, I'm talking about the bigger hospitals, Kolebu, Rich Hospital, etc. The complications tend to be something they see quite often. So it's a serious condition for us.
If you say complications, usually what does it mean? It means that you have the disease and...
Well, complications mean that you have the disease. For some reason, it hasn't been properly managed, and you have developed secondary conditions as a result of the diabetes. And
so
we can go into some of the secondary, I won't necessarily say opportunistic, but they have developed because you haven't managed your diabetes. If you understand how diabetes, the process of diabetes and how it works and destroys the body systems, it causes destruction over a long period, eventually affecting most of the vital parts of the human body, the eyes, the kidneys, the nerves, etc. You know, and when these start developing, then we see you are developing the complications of diabetes.
Professor Dodu, is it that we have had hindsight and not taken cognizance as countries, and so we've not had policy actions on them, or we've had them but just not communicated, or even if we're communicating, we've not been able to implement whatever policy actions there are? Because diabetes, from what he's saying, seems to be a very big thing.
All the things you said are true. We've known about diabetes. I think in Ghana, if you look at the research published from the medical school alone, from the 60s and 70s, we were leading actually in the world in publishing on diabetes. Then the prevalence was very, very low. I mean, we're talking about, I think it was less than 1%. As of 2002, it was 6.3%. And in fact, the figures, the estimates are difficult to get. And as Doc said, you can see it in the clinic. But I think the few publications you have, one says that as of 2010, there were 500,000 Ghanaians. And that is expected to be 1 million in the next few years. So even 1 million out of 25 million. But I think the most authoritative put it around 7%, 8% in 2012. So if you project, it's fair to say that roughly anywhere between 8 and 12% of Ghanaians, roughly 1 in 10, has diabetes. But the sad thing is that they don't know. Policy actions, you know, I think in Ghana we all know what happens. Things we don't kill us in big numbers and don't kill us spectacularly, they just pass. But Doc described it, and I have seen it from friends, family members, amputations, blindness. I mean, it's all over the place. And to the extent that we allow that to happen, for me, it is sad. People don't know they have it. That is the biggest problem. And it looks like we don't even care. And because it's not politics, we don't talk about it, because, yeah, people are dying. I mean, if you calculate, he said in light, it's a big problem. If you look at Konfandochi, it forms definitely one of the top 10 causes of death. The same for Kolebu. And it is a fact that in the next 10 years, diabetes, together with high blood pressure and public cancer, will kill us more than AIDS, malaria, TB, and all the communities. So whichever way we look at it, we have a problem coming. We can do the usual Ghanaian thing and say it doesn't matter and we all die, or we can wake up and smell the coffee.
Dr. Oduro, so it means that if people have it and they don't know, well, it's not as if to say ignorance is an excuse. Then something or a certain lifestyle they were living, or maybe some precondition factors in the environment may have predisposed them to be having it. What's making people get a lot more infected?
Well, let me start by saying that for most people who eventually realize they have diabetes, they'll probably have had it for 5 to 10 years before they pick up the symptoms, or before it shows out clinically. For which reason they might want to visit a health facility, which is why we always say that you should have regular medical checks, just to screen to see whether you have these conditions. Now, for the majority of people, the symptoms of diabetes, or how you know you have diabetes, starts with feeling tired easily, you thirst, okay, or more than usual. You realize that you have an increased need to drink. You feel you have an increased appetite, and yet you're losing weight. And then you seem to urinate a lot, at times more frequently, but it tends to be in huge volumes. You have a sore, it takes quite a while. People tend to develop genital itch, itching around their genitals, etc. So when you start noticing these, then it should draw your mind to the fact that you could probably be developing diabetes. Now, there are certain risks that increases the likelihood of you getting diabetes. A strong one is a family history. If your primary relative, I mean, if your father, your mother, your sibling has diabetes, the chances of you having diabetes is higher.
Meaning what? Is that what in medical terms you call genetic?
Yes, that's genetic.
Or hereditary.
Or hereditary, yes. So it's linked. If you look at your lifestyle, which is huge, because you can usually not pinpoint any specific thing. And here we are talking more of the 9 in 10, which of all diabetes, 9 in 10 tends to be type 2, what we call type 2, which you tend to see more in adults, but now we are even seeing the younger ones. It tends to be lifestyle related. And by lifestyle, I mean poor eating habits, a lot of fatty foods, etc. in the diet, lack of exercise, which is key, a sedentary lifestyle. And of course, obesity. Obesity is huge, and it's an increasingly becoming a burden. Obesity and overweight, it's increasingly becoming a burden. Those are huge when it comes to the risk factors for diabetes.
But he mentioned type 1 and type 2. For me, as ignorant as I can be, of course, I've gone to school, I do reading, I do research.
I'm not allowed to use that word.
But type 1 and type 2 just seem like any other disease or any other type of a disease that would affect you. What are they? And then how do they affect you differently? Let's say if you have type 1, what does it mean? If you have type 2, what does it mean?
I think to the layperson, simply type 1 is the one that, in the old days, we used to call it insulin dependence. You are born, you don't even have insulin, so you generally tend to need insulin injections. And usually, you have it from birth. And type 2 is the one, in the good old days, it was called maturity onset. As you grow older, you have it. And that's what doctor is saying, that forms 90%. So those who need insulin injections, I mean, you know it usually from birth, you have difficulties and you are diagnosed with diabetes and you need those injections throughout your life, usually. So that is the main difference. And of course, in a lot of countries, and you made mention of a policy issue in several developed countries when you have type 1. Because you are born with it, you need insulin, if you don't have it, you die. The state finds a way of looking after you for life. Insofar as the diabetes is concerned, because insulin is expensive. It must be kept in the fridge. You need needles, you need to check your sugar. It's a whole ritual. And even in some countries, type 2, once you are diagnosed with type 2 diabetes, government tries to see whether they can manage it. So, one, is a huge burden. It's a big cost to the individual. Managing diabetes appropriately is expensive. It is not cheap. You have to buy medicines, you have to buy those things, Lancers to, check your blood sugar. Ideally, you need a glucose meter at home so that you can do it yourself. You got to be trained if you are taking insulin, how to inject yourself, and if cost becomes an issue. So diabetes actually is also a very, very well-known cause of poverty, and it affects poor people as well. middle class, but it also affects poor people, and the poor are doubly affected. And for the one which affects 90% of the population, it tends to affect those in the productive years of their life. So here you are, you need to work, you have diabetes, you need to spend money, and if you go to the hospital too much, you don't get the money for the work, then you are in a cycle, and this is where you need state intervention. I am pleased that Multi TV has taken this up. I hope other stations will on this World Health Day and beyond. But if we joke with it, that will be our undoing. And I thought I would do the history on diabetes, because even this call by the World Health Organization today was made way back in 2011 at the United Nations. The UN never deals with health issues. But in 2011 September, they met and said, look, we have a crisis. The only time the UN has met on these things was HIV/AIDS way back. Now, if they are putting this thing in the same category in terms of the numbers of people to be affected and its impact on the world, then there's a problem. So in September, the United Nations itself, the WHO is a health agency for the UN, but the agency itself met and said, look, we are in trouble, diabetes, high blood pressure, and we must do something. 5 years down the line, WHO has come again. And for me, the question we ask is, between now and then, what have we done and what are we doing?
Because I also wanted to stay on you. It's very much easy for us to get statistics from the United States. And this one, very relatively and related, is how much is spent, the budget, the healthcare budget, let's say annually, of federal or state, but then also the individuals. In our part of the world, do we think of some of these diseases as not only chronic, but having impact on productivity as a result of that we plan towards them?
I would say that I've said this way back in 2011. We have infectious diseases of poverty, but trust me, non-communicable diseases can make people poorer. Another way of putting it is that diabetes can be a serious cause of underdevelopment. It will roll back what we have gained. And don't take it from me, the experts are there. There's a lady, a professor, young lady, Ahmad Akins. I read some of the papers. She's made mention of this. She's not the only one. There have been several lecturers in Legon, Tech, our universities. I'm referring to Ghanaian experts who have all done calculations. The average household may end up spending its whole monthly income in managing diabetes. Just imagine someone earning 3 million, 5 million cedis with diabetes. Just calculate. By the time they bought, if they are buying insulin.
You're talking old cedis.
500 Ghana cedis.
Yeah, but you're talking old cedis for people to better appreciate. I know.
Yeah, so they also need to be 5 million. So if someone takes home 5 million.
That's 500, and that's huge.
They can easily spend 500 or more a month on diabetes. Plus, Doc mentioned it quietly and gently, but he said kidney problems. If you have complications and you need dialysis, currently the rates are about 600 euros a week. No, 300 euros a week, which works to about 1,200 Ghana cedis a week if you need dialysis. So we are not talking about small figures. We are talking about big figures. It's been stated categorically that it will be a cause of underdevelopment. And if we want to move forward, diabetes, high blood pressure are things we need to begin to, screen for. For me, that is my biggest interest. Why are we not screening for it? It's not expensive to screen. And if you pick it up early,
but there's no strategy. So if there's no strategy, you can't do screening randomly, can you?
I agree with you that I was going to say something. These days I choose my words. Well, look, let me say it. After all, the reality is that as a country, we joke with health issues sometimes. When I say as a country, I'm not referring to the Ministry of Health. I'm referring to as a people. We are going to have elections in 2016. What has been the premium we've put on health? And here, I always...
And who is asking the questions, as the electorate?
Yeah, the electorate should ask. And I also feel that all of us, including myself, sometimes see the national health system as the government's health system. That is wrong. It's for all Ghanaians. So, for you to know how passionately some of us feel, way back in 2011, in my church, Holy Trinity Cathedral, I told the priest, give me money, and every Sunday, people should come for free screening. And we've been doing it for 5 years. You come in, we keep your records.
It's still ongoing?
Every week we do it. It's free. Because we feel like if people know, and since we started, I can't give too much detail, but a lot of people have needed to go for treatment. So what are the churches doing? It doesn't cost us. We bring 2 nurses, pay them something decent. The collections we collect in our big churches is massive. And we have been running it since 2010. Everybody gets a small health book. You come, your blood sugar, your BP, we check. And when you need treatment, we say go to a hospital so that you are properly looked after. These are things that others can do. So we can't leave it to government alone. I mean, I think all of us are a nation and we must find strategies. We can do small things, but like you're saying, maybe we also need the lead in ensuring that this is done across board. But the most you get involved with your money, the churches definitely. I mean, come on, look at the money we raise in all our big churches. If you are just screening your members for high blood pressure, blood sugar, body mass index, you'll be able to catch nearly half the problem. And once you identify it, the solution becomes a next issue, but that is a different matter.
And you made mention of how people are living with it and don't know. But how endemic or serious is it?
In terms of the numbers?
Yes, because you are seeing cases. You are telling me you see cases. So how serious is it? Is it that in communities, not you telling me about because we are 25 to 30 million Ghanaians, so maybe 5 million. No, I don't want that. But how, based on what you see, the frequency, etc., you can be in a position to perhaps postulate or perhaps guess what goes around. You know what we eat, you know how we live.
You know, as part of my introduction, I did say that a family history, for example, is key when it comes to developing diabetes. It's one of the greatest risk factors.
So that's what you look out for first?
So in the communities, if your father, your mother has diabetes, the likelihood that you develop diabetes with aging is high. So that is something you need to look out for. So if you are aware of this, then you probably go out to screen, because by the time you pick it up, you probably have had it for a couple of years. The lifestyles, and now we have more of a sedentary lifestyle because of our working conditions. We spend long hours in traffic, etc., especially in the urban areas. So our risks the risks are there, and it's, as Prof rightly said, in the very near future, the numbers are going to double and quadruple. The other condition that's increasingly becoming higher is gestational diabetes related to pregnancy. And it's also still because of our lifestyle.
Meaning what? You're pregnant?
You are pregnant
and you develop
complications. You are pregnant and develop diabetes.
Does it stay with you after birth?
Well, it doesn't usually stay with you after birth, but it increases your likelihood of developing diabetes later on, later in future. So because of the stresses of pregnancy and because of the lifestyles we have led, during pregnancy, the stress hormones pushes a lot of sugar into the system. It's not mopped up, and then you have diabetes. Usually after birth, it might go down, but you now have a risk. And with a little push, you become diabetic. Let's look at what is happening to our kids now in schools. Now, every kid goes to school with a juice, with juice.
You're saying it's wrong? My kids do that.
Well, yes, but it's wrong because unfortunately we are giving them so much sugar. Our children are all hyperactive. Why? Because we're pushing this so much sugar at specific points in time, and they become hyperactive, and we complain our kids are all over the place, etc. And we are pushing them with sugar. Our kids are now becoming obese. What's happening? We are increasing the risk of these children becoming diabetic in future. So if we do not take the actions, we're going to have challenges. And he talked about the economic burden of diabetes. I mean, it's one of the reasons why we have what we call catastrophic expenditures, unplanned expenditures, and they tend to be huge.
Catastrophic?
Yes, catastrophic, because it's unplanned. I mean, you have a budget for the month, and then you develop a complication of diabetes. You end up spending practically everything. It's unplanned, you know. And they tend to be huge, and the impact on the family, it's also huge. I mean, if your mom or your dad is ill in the hospital, you'll probably not be sitting here. You'll probably be there, okay? So that has an economic impact, it has a social impact. You won't be doing this program at this time, you know. You go to hospitals and have 3 or 4 people queued, waiting to visit or taking care of the person who's on admission. They would have been working. If they had, they would have been earning an income. But they lose all this because one person is there, one person is not well. You have the most productive person in the family now in hospital with an amputation, can no more work. What happens? The entire family suffers because the breadwinner had diabetes, didn't probably control it, and now is bedridden.
But he talks a lot. Expenditure.
Catastrophic expenditure.
Income earner. I mean, in my overall scheme of things, it also means that I look back on my life, on lives of many people. I look at the general aesthetics of the environment. We've actually developed from where we were some years ago to now, and we're likely to develop better. We go around, we see all these fried joints, chicken joints, junk joints, and things like that. But it also gives us a certain feel-good factor. We live in good houses, air conditioning, and all that. But the two of you are telling me it's risky.
Heavily risky.
Okay. If it's risky, it means that we should have something that says, well, this is what should enjoin an employer to do this. If it's on the health budget or whatever it is that you have to plan for, etc. As a country, we should be able to do that.
Yes, we should be able to do that.
When do we need to start doing that?
Now. And
how do we
do it? You see, the issue with Ghana is that it's always complicated. When you mention parliament, you be called to parliament. When you mention others, you have problems. But let's face it, we have a crisis on hand. You can quote both of us. We have a crisis, and that crisis will kill many. And I don't say can, I say will kill many. You know, the gone too soon that we've been hearing, we all know what is causing them. Diabetes will lead to complications in high blood pressure, you get heart attack. So young people dying 30 and 40 is not BEA. It is our choice. And it's going to increase, not decrease, unless we take action. I will repeat again, we have a crisis which will kill many unless we take action to reduce the numbers. It will still kill. There's, you know, sometimes we like to sugarcoat words. We are having development, but without the values that underpin development. Yes, you're saying KFC, we go there. We're saying McDonald's, we go there. They are nice. But go to Europe, go to America, people are trying to cut back because these things are becoming counterproductive. And they started 50 years back, not now. So when you take what is left over now, forget about, you know, the infrastructure. Number two, how well do we exercise? I've been through a lot of African countries. Take a country like Cape Verde, take some of the countries. Friday, they said, all of you, go and jog. Now come to the workplace. How many institutions, I'm referring to banks, the media, all those places, have schemes that ensure that their staff get screened for some of these basic things. When we use the word screening, people always panic that it's for HIV. So I say, no, we are not doing for infectious diseases. So that is different. We'll do that one too, but that is a different discussion. But screening for these basic things should be normal. I mean, I have done surveys. I mean, if I ask your staff right now, how many of the workers of multi-TV have checked their blood pressure in the past 3 months? I'm sure the numbers I'll get will be less than 10%. And yet you work in a pressured environment. You work under stress.
The media is stressful.
Life is stressful, but then you are working in the media, so it's more stressful. And in an election year, it's more stressful because of time. You need to be here and there. And yet, you're not checking your blood pressure. You're not checking your blood sugar. Journalists usually have the worst health indices next to health workers because you don't eat well, because you are busy. You have deadlines, you know, and then come to bank workers. And yet, here are institutions who have the financial wherewithal to have schemes to screen their workers and protect them. And let me just give you one figure. For those who are working, if you lose one very well-trained staff, according to the economists, not me, it takes about 4 times the annual salary of that person to replace the person. So if you have someone earning 20 million a year or whatever, 24,000 a year, if you lose him, it's going to take you 48,000 to replace him. In terms of the fact that his place is not filled, you get a new person, you train the person, you lose business. So losing one staff member is not good for any organization. And it's about time we all wake up and say, look, time to joke is over. I mean, my biggest worry is that in Ghana, we think everything is nice to talk about, big English, and then we go to bed and it's over. But these things are killing us, and we must do something about it.
Dr. Odro Mensah, what are the best practices in, always we have to say the developed or the better environment, which they use one for treatment, so if it's regimes, etc., and then also 2 for education, and then also if it's about getting them young, etc. That are perhaps replicated in other countries that we can have. I'm asking this question premised on the fact that, for example, you go to the UK, they have GPs in communities and things like that. But for us, we have one central, so you are the big one at La General Hospital and things like that. What are the best practices around the world that we can, perhaps, even though a small developing country, we can replicate?
I think in terms of healthcare facilities, best practice has been to strengthen primary care. Primary care meaning the CHIPS level, the health centers, the district hospitals, because they see the bulk of patients. And if you are able to build capacity at those levels, they tend to reduce significantly the number of diabetic complications that will eventually get to the higher centers where the economic burden is even higher. Promoting screening. That's where the policy issue comes in, where in other countries they have screening guidelines. At this age you do when you are at this age, these are the tests you mandatorily have to do. We do not have such a thing here. So it's something we need to also look at. Lifestyle modifications, it's key. And he talked about, aside screening, exercises. When you go into the Western world, yes, they may be eating all this junk food, but they have also built into their system ways of cutting down on this. Exercising, you can go on break and go to the gym and exercise and come back to the office. How can you do that here, in our society? And yet we have all these fast food joints springing up, and we are not putting in
you can't pay for the gym.
Well, but your officers should probably put some of these measures
so
in
that,
place.
that brings in the policy issue.
Yes. So those are the issues. And then the premiums on some of these, should I say, drinks and foods that increase our risks tend to be higher. So it's difficult. Now, even in some schools, you do not get sugary drinks in the schools. You have to bring them from home. You can get bottled water extra, So those are some of the issues we might need to look at. But let me add that the lifestyle issue is key, because that is one of the greatest risks to developing diabetes. If you are not exercising much, if you have a sedentary lifestyle, and by exercise, I'm talking about 30 minutes a day for about 5 days, regularly. You break into a sweat, and you can do it in maybe 2 equal halves. Morning, before you take your morning shower, before you take your evening
15
shower.
in the morning.
Maybe 15 in the morning, based on your schedule. You don't need to go full 30 minutes, if your schedule doesn't allow it. Ideally, you should be able to break into a sweat and moderate exercises. When you say exercise, some people go the first 2 days, they run from here to Kaswa. By 10 days, that's it. No.
So you're saying it shouldn't be strenuous. You take it 1 day at a time.
1 day at a time.
Then it becomes a habit.
You build up. You start 5, 10, 15.
Pharmacovigilance, and I have known you for I started general 16 years ago. I've known you. Yeah, I've known you. You used to work with Margaret, etc. And you've been involved in all this. He mentioned at the community level, where we're supposed to be having the CHIP compound, the graduate and all that. He talked about an ideal situation. You strengthen, you build capacity. How are we doing that?
I think on paper,
is it being replicated in other countries as well? In Africa?
In Africa, several countries are doing very well, yes. In Ghana, I think since 1977 was when we had this whole idea of primary health care. And by 1999, we've introduced the CHIPS compound. Okay, let's look at the facts. I think you have about 85% or so of all doctors, pharmacists, and nurses in Ghana in Greater Accra and Ashanti regions.
But that's bad.
I mean, so I hope the figures speak for themselves. So already we have a very, very seriously unequal distribution of health workers across the country. So as you go lower, you're expecting them to be looked after by lower level health workers. That in itself is already an issue. So we try to catch them young and bring them up into the higher level facilities. I don't think we are doing well. I don't think we have the number of doctors we need. I don't think we have the number of health facilities we need. You said other countries. For a country like us saying that we have oil, for me, I always say that we shouldn't aspire to the basic bottom level. I mean, fine, a country like Peru, but only small population. I think they're like 3 or 4 million. So, but they could institute some of these screening and other things, and they could have deaths from these things. Now you come to a country like the UK. I remember, I think early 2000, they said let's have a national service framework for heart disease and diabetes. And according to them, they managed to reduce deaths from heart disease by 50%. So countries, even when they are developed, sometimes it's all about the policy. How well do you see this, and how well are you going to invest towards it? And I mean committed investments. I have said this, I have worked in Ghana for the past 20 years. My biggest frustration is we are good at talking. When it comes to delivering, zero. And that one, I can be held to any court.
And then we don't prioritize.
Well, call it what you want to call it. We just don't do what we say we are going to do. And for me, it's my headache. You know, when will you stop? Is it till everyone is dead? Because, you know, it's quite sad when you go around Africa in particular, but the world in general, and you see that people are committed to what they say. So we say, we want to stop this. If the ministry is putting $10 million, put it on, call everybody involved, and drive it. But in Ghana, we'll talk nicely, we'll smile, we'll clap hands, and that is the end. And I've seen it on so many issues. And unfortunately, it's not just with the politicians. Even at church, oh, we'll do this. It becomes an idea. It's in Ghana when we intend to do something.
There's some level of laxity, you say?
There's laxity. For me, I say there's lack of commitment to our people. There's lack of...
Is it customarily? Is it something ingrained in our tradition?
I think so. I think we
just
enjoy the
back.
talking. No, we enjoy the talking, not the doing.
Like linguists.
My worry about that, Roland, is that, you see, we are bringing up the next generation to see that let's talk and go home. Nothing happens. But if we keep doing that, the day I'm dying, people will come and say, oh, Alex, you'll be okay. And I'll die. And they'll bury me. So let's stop the talking. Let's start the doing. Because at the end of the day, diabetes will kill us. High blood pressure will kill us if we don't start doing something now. It will kill a lot, but we can reduce the numbers it kills. Like it or not, they will kill us. They are killing us.
All right.
And we are joking with it.
But that's the current situation in which we have. We don't have enough of you in the lower echelons of the healthcare chain. So how do we manage it? Primary healthcare, etc. We're not going to have enough of you down there. How do we manage with the current situation we have?
Yes, with the current situation, education is key. Education is key.
So you're saying more prevention?
More prevention than cure. Okay. Because when cure comes in, then it has advanced. Yes, so education is key. We've spoken about the lifestyle modifications, and those are key. And then the issue of cure versus treatment, or cure versus management. And that is unfortunately the bane of our people.
Why?
Because there are people out there who claim that they can cure diabetes. Diabetes is not curable. You can manage it. If your sugar levels are well controlled, you are managing it. Whatever medication you take, herbal or orthodox, if it's able to control sugar level, you are managing it. If you have malaria and you take the anti-malarials, you've cured it. It will not come back when you stop the medication. But if you have diabetes and you use lifestyle or drug management and you stop, it will come back. So you only manage it. So it's key. We also need to train even the lower level personnel. And it's basically education. If the lower level personnel, even at the CHIPS, who cannot prescribe, can identify, pick up the symptoms, early symptoms, thirsty, drinking a lot, urinating a lot, you know, and then help you with the lifestyle issues, it helps. If we can get the agri sector, and this multi-sectoral, because it does not only affect health, okay, if we can come up with some policies with other sectors, that gears our diets more towards the vegetable sector, it helps. And let me just use this opportunity to talk about the diabetics diet, which is also key when it comes to dietary management. We hear a lot about don't eat this, don't eat this, don't eat that. I say diabetics can eat whatever they want, or whatever they want to eat. Exactly what the family eats, but it's the quantum that matters. It's the quantum that matters. A lot more vegetables, very little proteins, very little sugary or carbohydrates, but a lot more vegetables.
But even if they are natural, pineapple.
As much as possible, cut down on sugary stuff. Okay.
Even if it's natural.
Go for the vegetable, if natural or not. Cut down on the sugary stuff, because
no sweets.
You have a challenge with utilizing the sugar in you. That's diabetes. You have a challenge with utilizing the sugar in the blood. So why do you want to put in a lot? And yes, the body needs the sugar because the body has to function and the body needs the sugar to function. So you cannot cut down totally on the sugar, but you can moderate it. You can look at the frequencies you eat. If you take spikes, you know, when you input a lot of sugar into the system, you get a spike probably, okay? It takes a bit of time for the sugar levels to come back to normal. But if you are eating in small quantities at a time, 4 or 5 times a day, but in very small quantities, you get very small spikes and your system is better able to manage this. So we advise diabetics that when they are eating, they shouldn't take huge meals at a time. Just take small amounts, take some snacks, etc., so that your sugar is better controlled, because the long-term complications are serious.
Okay, so at the hospital level, you get to see how worse can a case be when it comes to the
well, death, if that is worst enough, death
No,
can
I
be,
don't
yes.
mean
But then, yes, we've talked about the burden of admission alone. Even admitting you to control your sugar is a huge burden, a huge economic strain on both the client and the family. We've talked about the other complications that come with it, loss of vision. You know, you are your productive age group and you're losing your sight. We've talked about kidney problems, and he mentioned the economic burden of kidney problems. £3,000 a week, that is huge.
What brings about the kidney problems, for example?
Well, the diabetes, the sugar destroys the kidneys. You know, so the kidneys are unable to function. The sugar basically destroys all the small vessels in the body. So it's the same thing happens to the eyes. It destroys the small vessels going to the eyes. It destroys the vessels going to the kidneys. It destroys the vessels going to the heart. It destroys the nerves.
Amputations. You are on amputations.
Yes, so amputations. Either they give you a trousers, which I call a trousers, or a shorts, depending on which level they cut, you know. And for some, losing the limb is enough reason for them to not want to live
Now I'm
again.
frightened. I'm getting all these goose pimples.
We are happy you are frightened.
Yeah, but it also means that we have to do a lot more of the replicated education. But then he mentioned all the people we encounter that the media is also bombarding the public with, who can cure, no policy direction. For example, there's an advert on TV. The person, you are told to take a prostate drug. And I know prostate is a chronic problem, is that not it? I don't know how you can take a prostate, because you come, how do you determine whether you can frequent urination or something? So because I'm asking this because we have all these churches, they can cure you. We have all these churches, you see them live on TV, and we, the media, have allowed that. They give live birth instead of going to the hospital. They believe that God can give you better birth than somebody God has empowered to help you give birth. What should we be doing about them? Policy direction.
I think the policy should be clear. In terms of the adverts for prostate and other things, there is a clear law that we are not enforcing. The laws of Ghana are very clear. It's written in an act that you cannot be promoting products for so many conditions, anything which affects the genital systems, anything which affects the reproductive health. All these laws are there and they must be enforced. But I think from the higher policy level, we need to encourage people to realize that, one, religious bodies, churches, mosques and co, should never confuse what I would call the orthodox healthcare and make it sound like it's demonic or it's wrong, because some churches preach that you have no faith if you go to see a doctor. That is wrong. I mean, I'm a Christian. I believe firmly that the good Lord gives us the knowledge to, move society forward. And so anybody coming with that, I tell them that then when you're going to the UK, walk to the UK, don't use an aeroplane. The good Lord has given us brains to serve mankind. Most of us in healthcare, if you are Christians or Muslims, see our jobs not just as jobs, but as our calling. That is also our service to society. So for me, any church who comes and says, I can cure high blood pressure, I can cure diabetes, the science does not support it, and I don't support it, and I'll tell the one you are wrong. If Jesus Christ were here, he will tell you are wrong. Importantly, I would like also to use this opportunity to tell Ghanaians that we should stop stigmatizing people who have diabetes and high blood pressure. Trust me, I have people calling me, crying that they have diabetes and they feel like they'll be stigmatized. And one of these days, I told one of my cousins who called me that he has high blood pressure. I said, do you know the medications I take? I cannot reveal my medical history on TV. I said, we all take medications, whether it's for high blood pressure, for cholesterol, for something. He said, since when? I said, oh, for about 5 years. You know, so we also have a duty to explain to people that having diabetes is not a death sentence. It's nothing to stigmatize people on, because that is going on a lot. So people are afraid to come out, even with diabetes. So please, 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 all of us have a duty to do. But I think the policymakers, and this goes directly to the Ministry of Health and to the government and to us in the government, not any party.
Okay, so we have to wrap up the conversation. Our time is up. But as we wrap up, how do you also complement in the education as you encounter your patients, etc.?
Well, I'll say that we tend to promote family care when it comes to managing diabetes, because it's not a condition for just one person. It's a condition for the family. So as much as possible, whenever the opportunity arises, we urge that we not just educate the clients who comes to us, but we take the opportunity to educate the family, let them understand exactly what is going on with that family member of theirs. Because any time there is a problem with that family member, the entire family will tend to suffer with it. Let's all try as much as possible to screen regularly for diabetes. It's not expensive. 5 cedis, 10 cedis a year. It's not expensive. How much money do we spend buying junk food? If we're able to do this a year, to prevent a lot of the complications we are seeing, because for most people, by the time you go to hospital,
you're saying at least in a year.
At least if you can do it yearly, at 6 months, every 6 months, yes.
It's
for
ideal.
those with risk factors, otherwise a minimum a year, because by the time you pick it up, you've probably had it for 5 to 10 years. For those who go to hospitals because of symptoms, but when you screen, you catch the pre-diabetes period. Start the lifestyle modifications, which is really key before we get to actual full-blown diabetes.
What do you do by way of education?
By way of education, I would just say that both the government, the National Peace Council, the religious bodies especially, we have a duty to our members, we have a duty to society. We must start educating, but importantly, we must start advocating for some of the things Doc has said, that collectively, as a nation, really, we must come together and say that, letting avoidable deaths occur is not acceptable for a country which wants to be developed. It's also not fair on Ghanaians, especially the poor and vulnerable, because what we are telling them is that we don't care. We, the rich, will go on and do what we want. And I pray to the good Lord. I always say that whether you are Christian or Muslim, when you get to paradise, God should ask you, what did you do to prevent these avoidable deaths?
Well, thank you very much. We've had in the studio Professor Alex Dodu, pharmacovigilance expert with the Collaboration Center of the WHO here in Accra. Thanks for joining me. Great having you as always. And also Dr. Ebenezer Oduro-Mensah is a family physician, but also a medical superintendent with the La General Hospital here in Accra. Thanks for joining me, sir. I've enjoyed my conversation. I've been frightened. I hope you've been frightened too. But the fear is not supposed to lay you back, but make you take a lot more action, because according to the numbers, it is real. It is real not only around the world, but also in a community near you, but with somebody close to you. So please get educated, and then you can also transmit a lot more education to other people. It's important. That's why the World Health Organization has the theme for today, focusing on diabetes, as it marks World Health Day today. We've had a great discussion on the subject, and I hope that you can continue a lot more of the discussion and education. That'll be it for talk for this morning. Next, we'll have to bring you entertainment as always. Please stay tuned.